Hello, good afternoon, good evening, where you are at, and you're welcome to the webinar on targeted and selective strategies for measles and rubella vaccination campaigns. It's our pleasure to share with you the interim guidance by WHO, and we'll be having a series of discussions that would span throughout this discussion session. We will just give a minute to have other colleagues join. And while you are doing that, it's my pleasure to introduce myself. My name is Onyavo Efe Aluta, and I work with WHO at HQ on measles and rubella. I'll be facilitating this session and working together with other colleagues from the region and also from countries as well. We move to the agenda, and I will just quickly show that here that we'll be having introductions and housekeeping coming up shortly. I'll be inviting my colleague to do that. We'll follow by having an overview of the interim guidance for targeted and selective strategies in measles and rubella vaccination campaign. That will be taken by Dr. Santosh Gurung. We would have opportunities for teaser questions that would come up. So we encourage you to please participate. We want to hear your views. We want to hear from you. Please use the comments, the Q&A icon to share your thoughts as we progress in this webinar. We have an interesting session on
Oni, are you back?
Yes, I'm back. Apologies for that. So I would like to invite my colleague Gigi to go through the introductions and the housekeeping. So Gigi, over to you, please.
All right. First of all, welcome everyone to this webinar session, and thank you for your participation. This webinar is hosted in collaboration with the WHO and TechNet21, and here are a few housekeeping items for you before we start this session. Please note that this webinar is being recorded and that we will share with you the links to the video as well as the presentation slides later on by email. Feel free as well to introduce yourselves in the chat box. Tell us your name, your organization, where you are from, and you can also use the chat box if you need any technical support. There will be interpretation services from English to French for this session. In order to choose the French interpretation, you can click on the interpretation icon, the globe icon at the bottom of your Zoom window, and then select the French language. If you have any question during the presentation, feel free to use the Q&A box, which is also available at the bottom of your Zoom window. Feel free to ask your question at any time, and our panelists will answer it after the presentation. And then finally, during the discussion section, feel free to raise your hands to be given an opportunity to share your comments or your questions. We hope you enjoyed this session, and now I will give the floor back to Onyovo.
Thank you, Gigi, and thanks everyone. So just to again emphasize, please feel free to introduce yourself in the comment section, and just to say we are very happy to have you. I will be inviting my colleague, Dr. Santosh Gurung, to give us a brief overview of the interim guidance, and we encourage that you share your thoughts and your comments on the Q&A section. Santosh, over to you.
Thank you very much, Oni. And just to be sure you can see my screen, right? The first slide to the presentation.
Yes.
Yes, we can.
Thanks for confirming. So my name is Dr. Santosh Gurung. I work with the WHO headquarters based in Geneva as a technical officer for measles and rubella. And I'll be just giving you sort of a brief overview in terms of this guidance that was published earlier in this year, what in terms of strategies for targeted and selective strategies in MR measles rubella vaccination campaigns. Just in terms of an outline, I will just give you the objectives of this guidance, and then I won't go through a lot of background because I have that as backup slides, which I can share with you after the webinar, but I will talk in terms of the concept around tailored and what targeted and selective strategies mean in this guidance. and then walk you through a couple of steps of how you can sort of, in a country setting, the decision making around going for a targeted and selective strategies in a measles rubella campaign. I'll walk you these 4 steps, and I'll sort of walk you through in terms of the making the decision for approaching a campaign, and then how do you target an age range, how you target the subnational or a certain group of people, and then eventually I will talk about selective strategies. So with this, the first slide, just wanted to let you know that the objective is really to support country level decision makers, but also partners at a global level and all the people who are involved in decision making and planning around um, SIAs mainly, but who have campaigns coming up in the next 1 or 2 years or so. This guidance, it's really a complement. You must have seen the measles rubella SIA field guide, which the link is up on the side. You can see it also in the graphic on the right, but this is really a complement to the guide and sort of narrows down in terms of a resource constraint setting, or if you want to go for a more narrow approach rather than the default 9 months to 5 years versus a nationwide non-selective campaign. So how do you go about doing that? And this really is a guidance talks that about the preventive campaigns in general, but it does sort of contribute to certain aspects around outbreak responses, and by no means it covers the periods or the periodic intensification of routine immunization. So just the concept around targeted and selective, and I think we did a lot of brainstorming with partners, with country focal points, and we really wanted to make it a country-centered approach. So we had a lot of country discussions also while developing this draft, and targeted in terms of the measles rubella campaign, we're really talking about the age range, right? So rather than the default 9 months to 59 months or up to under 5 years, what exactly and how do we go about targeting this age range? Then we also talk about targeted with regards to geography, mainly other than the nationwide, how do we go for a subnational approach? And then eventually certain area or certain groups of people that are at high risk, how we sort of include them in this targeted approach. And my second aspect of my presentation, I'll be talking about selective, and selective by every means, it means where you are only vaccinating the eligible people who have missed the doses of measles, rubella, MCV1 and MCV2. And I will be talking in terms of what is the cutoff and how do we sort of go about making the selective strategy approach. A very quick outline. I won't go into the detail of this slide, but just sort of giving you every 4 steps, right? Like you have routine immunization or EPI in the country, and if you have a strong routine immunization, so if there is still an immunity gap, do you need a campaign? That's the first question you need to answer. And then once you sort of get a clarification, you need a campaign for measles rubella, then how do you sort of target the age range, certain geographies, certain groups of people, and then you go for the last question around selective approach. Again, this slide is very detailed, but my subsequent slide, I will be talking more in length, and we have already fantastic group of panelists today who is sort of going to really sort of make this more realistic by giving country examples. And we have country examples from India, we have from Rwanda, and then we have the Afro region also sort of talking about this, but also from a different disease perspective, we have what it means by targeted and selective strategies. So really the step 1 is, I think if you've identified that a campaign is needed in the country, right? I think the center point or the crux of all of this is gathering available and accessing those data, right? And at a national level and at a subnational level. So there are different data points in the country, and it's very important to sort of bring together all the data and sort of triangulate and use it best in terms of decision making for a more narrowed approach for targeted and selective strategies. So you have sources like the vaccination coverage by age group. You have the measles case-based surveillance data that comes in on a weekly basis, on a monthly basis. It really differs from country to country. And then you have the estimation of immunity profiles, which I will be talking about. You have migration patterns, you have demographic data. Some different countries have different aspects around collecting zero dose and the under-vaccinated kids, and assessment of local programs and service delivery. And there are additional sort of information, qualitative information. If it's a fragile and a humanitarian setting, I think those factors, those need to be factored in, and also different partners in the country where you sort of need to factor in and sort of gather all the data. Now, the next step is really, it's the step where you sort of have the data points and you sort of want to determine the age range for a vaccination campaign in a measles rubella setting. And I think age range is one of the first decisions to be made about a vaccination campaign. And just for the ease of implementation, I think the guidance really talks about having a continuous age range, like from 9 months to 10 years or 9 months to 7 years, just for the ease of implementation. And I would like to sort of, in the guidance, we really talk about 4 sources that is very helpful to determine the optimal age range selection for an MR campaign. And the first being, when did you conduct the last measles rubella SIA? So once you determine the year, then you include all the birth cohorts from that year forward. You specify the campaign eligibility based on the year of birth, and then the best practice is to include the youngest cohort, as only a portion of them could be vaccinated in the past campaign. The second aspect is really around the immunity gaps at a subnational level, and different campaign age ranges may be justified at subnational levels, especially if a birth cohort or a geographical area was previously omitted or had very low coverage. There are special considerations that must be taken into account when determining the age range at a subnational level, because it's really at this point where there is a lot of issues and concerns around the accuracy of data. So there is example of overestimation of population immunity for certain age areas where coverage might have been calculated using outdated demographic data. So it's also important to sort of triangulate this multiple data sources to ensure there's accuracy because of the data quality. And in cases where you don't have the data quality is suboptimal, you can use the surveillance data on age-specific incidents, case distribution by age group, vaccination coverage, and so on. And of course, taking into factor of the local context in terms of supply interruptions, humanitarian setting, those population that could have been missed during that setting. So this is the second data source. And thirdly, I think the immunity profile, which I alluded earlier, I think most of the colleagues who work in the measles rubella space, they are very familiar with the measles population immunity profile, which sort of estimates and visualizes the percentage of birth cohort immune or susceptible to a measles based on vaccination coverage. This gives you an indication when an SIA should actually be conducted regularly when the measles susceptible children under approaches in one birth cohort, right? So this has been instrumental in countries, and CDC has helped, but now the regionals are also working with the countries in sort of doing the measles population immunity profile. And then you have to include in the guidance what I think the guidance talks about, including birth cohorts with more than 10% measles susceptibility. And like I said earlier, to create a continuous age range for the ease of implementation. Lastly, I would say using surveillance data, which is very important to assess the proportion of cases by year of age and population. So include annual birth cohorts in the campaign age range if they represent more than 20% of the confirmed. And when I say confirmed, it's lab and epi-linked confirmed cases in the previous 12 months. And analysis by single birth year is preferable, but I think in instances where there might be certain clear evidences when an adult immunity gap is associated with the measles virus transmission to infants and the young. I think you can, in that instances, there can be a non-continuous age group for selection of the targeted age range. The step 3 is more around geography and certain groups of people that you would want to, high-risk group of people that you would want to include in the campaigns. And I think the decision for a targeted strategy should be guided by the assessment and availability of the quality of data, which is step 1 that I talked about earlier. And at the subnational, I think 2 critical data points are the measles and rubella vaccination coverage through the routine immunization, but also through the previous SIAs, and additional information on certain special populations and operational capacity. And then there is a lot of like the measles risk assessment tool. This doesn't really help you to determine whether a campaign is needed or not, but I think you can use this tool to sort of get to the point of the risk stratification around low risk, medium risk, and high risk, and determine whether what kind of intervention is needed. But also, having said this, I think you have to take into factors integration with other programs, which is a key component, but also if non-campaign strategies are more effective than just doing the campaign approach. And of course, the equity and the exclusion criteria is also something that needs to be taken, because you are sort of missing out on certain groups of people that will not be vaccinated. And the questions around the local health capacity is also important. This may be I think the last content slide in terms of selective strategies. And I think once decided on a targeted versus a nationwide campaign, a country should really carefully consider if a selective strategy is warranted, right? So with a selective strategy, MR vaccination is only administered to those who are missing doses. This does provide a significant cost saving in terms of vaccine doses, depending upon the implementation model. But the operational cost, it might be same or greater than that of the non-selective campaign. So there is no very clear evidence that it is more cost effective. It's really a common practice that's used in school vaccination entry, but also in PERIs, like I mentioned, and also used in integrated campaigns. Only vaccinate individuals without documentation of previous vaccination. And in the guidance, it talks about having a threshold of 90% documentation of the cards, so that then only you're eligible for a selective strategy for MR campaigns. These are certain campaign strategies if a country wants to do a selective strategy, but this is so I think some of this model will be discussed by the country panelists. And this last slide, right? Like it really talks about the different, the countries can choose like different strategies. No, it's not that targeted and selective strategies are mutually exclusive, right? A country could go for, so you have a table that kind of nicely lays out in terms of a national versus subnational, and whether a country can go for a targeted versus selective versus nationwide versus non-selective. So we will be listening to more country examples around this. And lastly, I would just like to, I think this is my final slide concluding that campaigns, I think in this resource constraint setting, right, like rather than go by the default nationwide non-selective campaign, this is an effective strategy to sort of go for a more narrowed approach by going for targeted and selective strategies. Guidance includes important considerations and decision-making around the strategies. But also, I think it really reiterates the importance of making the home-based records, right? And improving the availability of the home-based records, and the monitoring and the evaluation bit is also very important, which is also included in the final part of this guidance. So I don't know if I stuck to time, but over to you, Oni. Thank you.
Thank you, Santosh. You did excellently well. Can you move to the next slide? So you've heard about the steps to take in gathering available data, how to determine the age range, targeted strategies in geographical areas or high-risk groups, and you've also heard about selective strategies that you can use. So we want to really point out to you again that we've shared on the chat the link for the interim guidance. So please feel free to click on it and download it. And we believe that it will be very useful in your campaign planning. We have a few teaser questions for you as you participate. So I'm going to ask Gigi to prompt the first teaser question. And it says, are you familiar with the targeted and selective strategies? So we want to hear your feedback, if it's a yes, if it's a no, if these concepts are new to you for the first time, that's okay. If you're used to, if you're familiar with them or you've used them before or heard about them before, that's also fine. So we just want to get a sample from you on your familiarity with the targeted and selective strategies. Okay, maybe we'll have the results on this and then we'll move to the question 2. Gigi? Right, so we had 79 people saying that they are familiar and 79% and 21% saying no. Question 2 is coming up. Gigi, can you put up question 2, please?
Yes, I'm doing this right now. Here you go.
So it says, have you been part of the implementation of such strategies? So one again here, in your country, your region, wherever you may be working, this strategy is part of what you have used previously, or are they completely new? So please feel free to provide your comments. Okay, we have 68% saying yes, they've been part, and that's really excellent. So it means that this discussion is useful. And we have 33% no, which is also important because again, it means that it's in this conversations we're having, you will find them helpful as well. We'll move to question 3, and we'll also ask that you hold on because you're going to be hearing from the country examples and regional discussions as well. Question 3 says, would you implement these strategies in resource-constrained settings? So do you think that there is some value in the implementation of these strategies in areas that are constrained with resources, or you think otherwise? So we'd be happy to get your comments on this. Would you implement these strategies in resource-constrained settings? We talked about the 4 steps, how to gather your data, to determine the age range, what to do in targeting in geographical or high-risk areas, and then selective strategies as well. So we have 93% saying yes, and 94% saying yes, and 6% saying a no. Okay, that's great. All right, thank you so much. You're all very excellent participants, and again, want to encourage that you share your questions in the Q&A section and your comments as well. We would love to hear from you, either your thoughts or any questions you may have on the discussions as they evolve. We will be moving to the panel discussion, maybe the next slide, and it will be my good pleasure to introduce to you the panelists that we have to guide this session. Santosh, do you want to go to the next slide? So we have, for the first, we have India, Dr. Ratnesh Murugan. We have from Rwanda, Dr. Hassan. And we have Dr. Baucha Masresha from the Afro Regional Office, is the regional advisor for measles and rubella for the Afro region. And we have Dr. Sylvester Malegemi, who is from HQ. I will be inviting the panelists to please put on their cameras as we commence the panel discussions. And we hope that as they do this, you would hear from them factual experiences with regards to how they have implemented the strategies or what they are currently doing to take it forward. Our first panelist will be Dr. Ratnesh Murugan. I would like to invite him to please introduce himself before I ask him the first question. Dr. Ratnesh, you're very welcome, and over to you.
Thank you so much, Dr. Oniovo, and it was pleasure to meet you all. And thanks, Dr. Santosh, for setting the perspective. I am Dr. Ratnesh Murugan. I am the National Professional Officer for Measles and Rubella Elimination at WHO Country Office for India. And I've been working with WHO from 2001. And from 2005, we started with the measles rubella surveillance. It has been from 20 years, we have expanded rubella surveillance across the country. And over a period of time, we have good experience of campaigns. We have good experiences of intensification of routine immunization. And the country is on threshold of achieving rubella elimination, but slightly off track for achieving measles elimination. So looking forward for all this discussion. Thanks, Oniovo. Thank you.
Thank you, Ratnesh. We hear exciting things are happening in India, and we're really happy and thrilled to hear the India perspectives on what we're talking about. There are a lot of participants on board that are wondering about the concepts of targeted or selective strategies. I know you have a campaign coming up that you intend to use one of these strategies. Do you want to just quickly talk about it and some of the areas you're looking at, how you intend to go about this, and challenges if possible? Over to you, Ratnesh.
Thanks, Oniovo, for that question. Actually, this interim guidance has come at a very opportune time, and it is very good. And we are I've gone through this guideline. It is clear. It is explaining very clearly what is to be done. And a few examples in the country of India, what we have done here is we have done a non-selective national-wise campaign from 2017 to 19, from the age group of 9 months to 15 years, where we have covered in phase-wise manner, because India is a huge country, we covered in phase-wise manner. Around 347 million children were vaccinated with one additional dose of vaccine. That gave us a very good momentum. And then our MR epidemiology, measles rubella disease epidemiology, it changed over a period of time from that. And followed by that, COVID, of course, it came out. And then we, in year 2023, we had a national selective campaign. That is, we called as intensified mission Indradhanush. It is more of a intensification of routine immunization activity in 23. It was a selective one, where the children who are left out or drop out, who are under vaccinated till 5 years of age, they were identified and they were vaccinated across the country. That was also done. And the third one, which we are looking up right now, which Dr. Santosh has clearly mentioned, the subnational targeted one, which we are planning for 2026 January, which is which we are targeting 9 months to 10 years. And it will be a selective campaign where we are focusing on whichever the child is wished out. But the age group is 9 months to 10 years. So that is something which we are focusing upon. Thank you, Dr. Unio, on that.
So you're doing selective, you plan to do selective vaccination campaigns, looking at age group 9 months to 10 years. Are there any challenges you think you may encounter in this? And how are you navigating your data on this?
Okay, thanks, Sunil. Actually, during the selective one, which we have all previously done, some challenges which we could find out during the intensified mission in the Dhanush was like the identification of beneficiaries. That was a very big challenges to how to identify the beneficiaries who are left out, who are drop out, and it's a very big country, and only the headcount surveys will not going to help. And then once, even if you identify the mobilization of beneficiaries to the station site, that is something big challenge. Huge urban areas are there. The person who is identifying the beneficiaries and the person who is mobilizing the beneficiaries are completely a different one. So whoever they have done, one person has done the identification, he has left. And the second person is doing the mobilization, he doesn't have any sync with in the community. So that is a challenge where the people are not getting mobilized to the session sites. And what we have also seen that even if you do, the same children who are getting the vaccination are repeatedly coming. And the children who are getting missed, they continue to be missed because of the migrants, because they go from one area to another. And once the migrants are there, there's a huge migrant influx. And once the migrants are there, they are not in the database of any health worker to track them, to give the vaccination. So that is something which is there. And urban slum is, of course, a big challenge. And there are few areas of vaccine hesitancy also, which is a big challenging for us when we do this selective campaign. that was something which we had to.
But as you move to 2026, where you plan to do selective, and I think you have a couple of districts you're looking at, how do you plan to combat these challenges? Because I know that there are quite a lot of countries that are either anticipating having these same challenges as well. So how do you envision that you're going to navigate them?
Yes, thanks, Onyo. Now we have learned from the challenges. We know what are the challenges. Now going forward, what we have done here is how we are preparing, because it is coming up in few months' time, January 2026. So what we are planning here is we have divided the age group at different categories. One is the school-going age group. Right from India, from 3 years onwards till 10 years, they are in the schools, whether it is a preschool or in the school. And 9 months to 2 years, they will be in the community, where we have to do in the community. So the community and then out of school children, how we are doing is we are going to do house to house search, head count survey to find out left out and drop out children, enumerate, line list them, and then we have to have a plan to mobilize them to the session sites. The second one is a tricky one, which is a school one. What we have done here is, rather than doing the headcount survey, which is not going to help, we have given the interested that role to the school teacher itself. The school teacher will be responsible for collecting the vaccination card of all the students who are there in the school. They will be keeping it with themselves, and our health workers, maybe 1 month prior to the campaign, in medical officers will be visiting the concerned school. They will be scanning the immunization record, and they will be communicating back to the teachers who are the children who are eligible for vaccination, who have to bring it. If suppose some children has not given the vaccination card, the teacher is again going to inform to the parents that please send the vaccination card. Even after the reminder, if the vaccination card doesn't reach the school, we will consider that child is unvaccinated, and we will give the child the vaccination. So this is how we are going to overcome the challenges. And we are planning for additional session near to the community, which is a mobile session for migrants. It is very difficult. Our mobile team will go and vaccinate at the timing is also flexible. It is not that only morning hours. Even in the evening hours, we are planning to do the session site where we have to do. And all the urban settlements, and even in the, like in previously IMI also, some of the areas, weekends also we use it as an opportunity where the parents are there, they can come and take the vaccination. And that there is a digitalization of all the beneficiary record, which is also happening in the country, which is all helping us so that the lessons which we have learned from previous few campaigns, we are going to incorporate. And this interim guidance, of course, will definitely help us a lot. Thank you, Dr. Unya.
Thank you so much, Ratnesh. It's really great to see that India is working towards this, and it's good to really see how you're using your home-based records and screening to ensure that your selective strategies are being implemented the way it should. So thank you so much for your feedback. So colleagues, you've heard from India, and you've seen that they have a selective campaign planned in 2026, just like what Dr. Ratnesh said. I will be moving on to another part of the continent, Africa, and it's my pleasure to introduce to you Dr. Hassan Sibomana from Rwanda. We're very happy to have you, Dr. Hassan. Do you want to introduce yourself and also just quickly let us know if some of these strategies that we've talked about are applicable in your setting or not, and what exactly you're doing to ensure that they're effective? Over to you, Dr. Hassan.
Yeah, thank you, Dr. Ani. Thank you for having me. So it is my pleasure actually to be part of this forum. So my name is Hassan Siwamana. I'm the EPM manager for Rwanda. I'm working with the Rwanda Biomedical Center. So Rwanda Biomedical Center is affiliated agency of the Ministry of Health, where actually all programs actually are being implemented, including vaccination program. Yeah, and then for your question, this is very interesting because actually I'm very happy that actually now this strategy is being disseminated, because actually for us we conducted this targeted campaign last year in June. So can you imagine, actually we tried our best to implement even the vaccination campaign targeting some districts without necessarily waiting for the guidance from WHO. And of course, I'm very happy that actually have been in touch with W country office, WHO country office, and the regional office, and they encourage that actually it is possible. And for us in Rwanda, we have in total 30 districts. And for us, actually, we targeted only 19 districts to be to vaccinate for measles and rubella. And this was very important for us because actually the previous campaign, actually it was implemented in 2017. So actually it was more than 5 years. And for us, we have seen that actually there is no way of continuing actually vaccinating all countries, the whole districts, because definitely we have seen that actually there was some districts with a very good vaccination coverage, closer to 100%. And we tried our best to assess if there is a number of children who were not vaccinated in those districts. And we have found that actually most of the districts, actually there was no issue. And then we selected actually very few districts actually to be part of this campaign. And one of the criteria we have chosen, actually, it was to see what is the vaccination coverage. Is it below 90%? And then what is the status of measles actually in those districts? How many cases actually they have been reporting on an annual basis? And of course, we tried our best also to check those communities actually susceptible actually of developing measles. And for us, we have also included districts actually hosting refugees, because definitely we have so many refugees actually in our country from neighboring countries. And then in total, we have tried to target only those 19 districts. And we are very happy that actually the objective was achieved, because the vaccination coverage in all those districts, 19 out of 30, so 95.3% of children have been vaccinated. And then the target population, actually, it was children 9 months to 5 years. So what we
Wow. Thank you, Dr. Hassan. I think this is quite remarkable, right? Because when we talk about targeted campaigns, many countries feel you'll be excluding others, and they actually have concerns about the quality of implementation. And some have tried it, and I've seen outbreaks in other places as well. So they generally tend to want to do a nationwide campaign. But you have done a targeted campaign, and you're saying that you had 95% success rate. So I just want to ask, is this cost efficient in your opinion? And what were the challenges you went through, and how did you surmount this?
Yes, of course, this is cost effective, because definitely if you compare actually even resources used for 19 districts, actually it is quite different from the one have been using for the whole country. And of course,
Yes.
there was some challenges. There was some challenges because actually you will find that actually there is a high demand. Because if there is a
Okay.
district not vaccinating, actually they will be complaining. Why are you vaccinating in neighboring district? Why not actually in our district? And that is
Absolutely.
actually questions I have been receiving during that campaign. And actually, what we have seen also as another challenge. So most of the time for us, we are planning this month's vaccination campaigns for 5 days from Monday to Friday. So we have seen that actually our healthcare providers are overloaded. So the workload is very heavy. So meaning that actually this is something also we need to discuss internally and see when we are conducting this kind of campaign, we need really to limit actually only 5 days. That is also one of the challenge. And another challenge actually is, as you said, actually, as my previous speaker said, actually, so there is always a number of people hesitating actually to be vaccinated. So we have also some communities actually hesitating to have the vaccine. So this is something happening everywhere when there is these campaigns. And sometimes actually we are also requesting also the consent from parents, because sometimes actually we are also vaccinating children in the schools. So those are small challenges actually we have been having during this campaign, but we tried our best to solve all those issues. That is why actually even the achievement was very good. 95% actually it is a very good achievement.
Thank you, Dr. Hassan, and really, really, really impactful. I think one of the points that you really made that resonates very strongly with me is that in some districts, people were concerned, why are you not vaccinating their districts? And so you really had to take out some time to explain to them why it was a targeted campaign. And I think that it's a very important point amongst other things that you have said. So I want to come back to our participants. You've heard from India, you've heard from Rwanda. Want to ask you to please use the Q&A icon to share your thoughts, your comments, your questions. If you have experiences in your countries as well, please feel free to share your comments. We're going to have a discussion session where you may also be opportune to speak up. We want to hear your country experiences as well, and also have the privilege of responding to your questions. We will move to, so thank you, Dr. Hassan, and thank you, Dr. Ratnesh. There is one person that you need to hear, and it's my pleasure to invite Dr. Balcha Masresha. He's the regional advisor for the African region on measles and rubella.
Onyovo, I think your screen froze. Maybe your network is having a problem.
Do we want to go ahead with the question?
Okay, I think I can go ahead and just introduce myself.
Yeah.
So good afternoon, good evening, good morning, colleagues. This is Balcha Masresha from the WHO Regional Office for Africa. I coordinate the measles and rubella elimination work in the Afro region within the vaccine preventable diseases program of the regional office. Basically, I run a one-man team, one can say, in terms of coordinating the measles rubella work in the region, but definitely the bulk of the work gets done at country level. So I can say that I have a big team working towards measles rubella elimination across the region. I think we have lost Oni, but I can go ahead and say a few words to start with while waiting for Oni to join. So this guideline.
Did you want me to come and ask you maybe I think the question that Oni maybe wanted to have asked you is what kind of data should country program managers examine to guide the decision making on targeted and selective strategies in MR vaccination campaigns?
Yeah, okay. Thanks so much, Santosh. So before going into that, I'd just like to say a few words. One is we all acknowledge and realize that the measles virus is the most highly infectious pathogen known to man. And if there are any immunity gaps within a population, within a subpopulation, the measles virus will find it. And hence, we tend to aggressively implement preventive campaigns on a frequent cycle in order to close immunity gaps and protect particularly the most youngest and the most vulnerable populations. So that fact, the necessity of campaigns, is not changed by this guideline. I think we need to be very clear about that. The necessity for doing preventive campaigns, for closing immunity gaps, which we have not been able to cover through routine, I think that fact still remains. Of course, ideally, countries should aim for 95% and above coverage through both doses of routine immunization vaccine, first dose and second dose. If we can achieve that level of protection through routine, we will not need campaigns. But if our coverage has not attained that level of high percentage coverage, and if we have not been able to sustain and maintain that high coverage for a number of years, there will eventually be an accumulation of susceptible population over a course of a number of birth cohorts, which may result in measles outbreaks. And that is when we will need to do a preventive campaign. And the only thing that this guideline here is changing is, are there any conditions where we might need to scale down from a nationwide campaign into a more targeted or a selective approach? And yes, there are possibilities of doing that. And this is what this guideline is doing. We've always been talking over the last 10 years, I think, about selective campaigns, targeted campaigns, without being able to define them in meaningful terminology, define them in objective ways so that we can all use the same definition. So this guideline basically teases out those definitions so that we can all speak the same language. So there is tailored campaigns where our approach to campaigns, whether it is non-selective or selective, nationwide or subnational, our approach to campaigns basically operationally addresses the geographic realities within a certain subpopulation. So for instance, the size of vaccination teams that we use in a sparsely populated arid area versus the size of and the geographic scope of vaccination teams that we use in a densely populated urban and peri-urban area will definitely have to be different. The number of days, the length of service delivery will definitely have to be different. The number of supervisors that we assign for these different teams will have to be different. So that basically means tailoring our approach to the geographic realities. Then there is the targeted and selective that we're talked about. So targeted is when you choose a geographic area, when you choose a population subgroup. It could be by age, it could be by profession, it could be by circumscribed within a certain subset of population. It could be a prison population or a college population where you have had measles outbreaks. So targeting that geographic area, that geographic population subset is targeted campaigns. Selective and non-selective refers to whether we vaccinate everybody in the area that we're targeting or whether we look for evidence of vaccination and then exclude some children, some subjects because of proof of having had previous vaccination. So those are all technicalities, but we need to be aware of them in such a way as to be able to determine which one best fits within our own country context. Okay, that's one. The other thing, of course, is we have a WHO SAGE guidance basically clearly indicating which are contexts where we can choose targeted or selective approaches. And I think the WHO guidance, published guidance, actually mentions that countries that have medium levels or high levels of incidence, or countries experiencing periodic outbreaks, countries where population immunity is considered to be inadequate because MCV1 coverage is below 85%, for instance, or has been below a certain level for many years. Those are contexts where targeted or selective approach may not be the best way to go. So we may resort to our usual approach of non-selective mass vaccination on a nationwide scale. Okay, now the push now is because we have resource constraints that are unforeseen and that are unprecedented within the global health realm, within the global health financing context, we may be pushed or we may be obliged to really target our approaches. And this is where I think the next step comes, looking at what is the data that we need to make decisions whether we do targeted, whether we do selective approaches. Okay, and in this instance, we need to look at vaccination coverage by age cohort. So routine immunization coverage for the last 5-10 years for each birth cohorts. We need to look at vaccination coverage by subnational level. So it's not only the national level coverage, but we need to look at district level coverage if possible, provincial level coverage if district is not available. And of course, we know administrative coverage is hugely a challenge in many countries. So that will continue to be problematic as it relates to the reliability of the data, the quality of the data, to make a decision to exclude some groups. The same holds true for disease surveillance data. We need to have had good quality disease surveillance for many years. We need to be able to look at disease surveillance data to determine patterns of occurrence by age, vaccination status, geographic area, population subgroups, and not just age groups in gross terms as we often use, but individual birth cohorts. to be able to make that decision on whether certain birth cohorts have high incidence that requires that they be targeted, or certain birth cohorts, certain geographic areas have low incidence for quite some time, and triangulated with population immunity that can give us the confidence to exclude them. Another factor that we need to look at, which is really critical, is of course the denominator data. And when I mention denominator, of course, we're talking about the population data, accuracy of data vis-a-vis the proportion of population within a certain birth cohort or within groups of birth cohorts as projected from a recent census, or as can be elucidated from a very recent census data. Unfortunately, in many countries, particularly the big countries in our region, the most recent census is probably 15, 20 years back. And so projected data from way back from 20 years will not necessarily give us the level of confidence that we need to make decisions on whether we have the accurate denominators against which to interpret coverage data or disease incidence data. We need to know population migration patterns. We need to look at other factors, trait factors that may be relevant vis-a-vis the presence of population groups that are known to be resistant to vaccination in certain geographic areas, for instance, for different reasons. We need to understand service statistics with good confidence for us to be able to make a decision or make a reliable decision on whether our routine services have reliably been servicing a certain population, enough so that even if there are lingering population immunity, we can have the confidence that they will be able to service the population through routine services as opposed to doing a campaign approach. Other data, as much as we can get, modeling data, serosurvey data, data with regards to behavioral and social determinants of vaccine acceptance, seasonality of measles occurrence, all of these are data pieces that need to be considered as we look into whether a targeted approach, a selective approach, would be the appropriate fit for our country's use. So just in brief, these are some of the key points that I wanted to mention. Probably we can come back to them in questions and answers. Back to you, Oni. Thank you.
Okay, thanks a lot, Dr. Balcha, for this excellent insight and very detailed. And so I think we move on to the next panelist, right? So we also have WHO HQ and Dr. Sylvester, who's joined us in this session today. Maybe I would like to request you to put on your camera if it's possible, and just like maybe introduce yourself, but also please share your views on targeted and selective strategies and how significant these strategies are in a resource-constrained setting. So over to you.
Thank you very much, Dr. Santosh. Good morning, good afternoon, and evening, colleagues. My name is Sylvester Malegami. I'm the technical officer in the WHO HQ, but I cover 3 areas: coverage and equity, and of course, I also cover polio impact. So I have a rolling function in terms of integration. And I think the way I approach this, Santosh, I'll do it a bit slightly different, and I'll do it based on the different areas that I cover. So I'll first start with the easiest, which has to do with what are the risks and caveats when we talk of integration. I think the first, targeted campaigns, as the case may be. Then I'll go on to specifics in terms of polio, yellow fever, etc. So 3 things we need to be careful of, and I'm happy that Dr. Balcha has mentioned one of them or all of them, but I'll just reemphasize it again. Number 1 is the way we must do our targeted or selective campaign. We must be careful to avoid, deepening disparities in less prioritized regions because of issues around equity. The next thing we need to be watchful of is community perception, and I'm happy that the colleague in Rwanda covered that also. We don't want to trigger social tension. And I think the most important thing also is issue of data limitations. I mean, it's very, very clear. Where you have outdated data, we might be hitting the wrong 3, as the case may be. Then some of the considerations we think about as we talk about targeted or selective campaigns, especially in terms of integration, is number one, it could have a bit of complex coordination. It could be complex, you have multiple actors, different funding streams, different timelines, and that could be an issue, whether it's a selective targeted campaign or a nationwide campaign. Then again, you have overload, work overload, There's even issue around messaging. You have a lot of vaccines, you have different communities, it's targeted, it's selective. Then you have lots of issues around our messaging. So I think for me, those are the really important caveats and risks I wanted to mention. But in terms of your question, Santosh, I think in resource-limited setting, targeted and selective approaches are not optional. I think they are essential in today's world, and I'm happy that Dr. Bacha really, really emphasized that. And the reason is because, number one, these prioritize high-need populations and geographies. Then where we have limited resources, funding, personnel, logistics, it's very important. Then it helps us to maximize impact and equity. And now to some specifics, the area I cover, which is polio. Targeted and selective campaign it's not new to polio, actually. We've been doing it, but I'm happy that with this guidance, it's going to be a bit much more systematic. And I'll give you an example. When we do our micro-planning at the settlement level, we think of nomadic routes, we think of the farmers, we think of conflict settings. This micro plans covers those areas. That is just that is targeted campaign that we've been doing for quite a while in the polio field. You look at our post-campaign evaluation, intra-campaign monitoring, and lot quality assurance sampling. This helps us define where we're going to do more POPs, where we need to intensify efforts. So these are actually targeted approaches that we do in our own different areas. And again, I think if you even go towards yellow fever, before we do our yellow fever campaign where we have an outbreak, we do what is known as the risk assessment. Already in crafting the risk assessment, we already have a bit of targeted set in that set piece. I think I'll end by saying, if you ask me how do I define targeted campaigns, I'll say, look, this is a campaign that allows government and partners to prioritize the right intervention in the right places for the right population. I think I'll stop now and hand it back to you, Santosh. Thank you.
Thank you very much, Sylvester, and really thank you all the panelists for such an insightful discussion and at least perspective in terms of the different targeted and selective approaches. So I would sort of move us to the next step, which is the discussions. I think we want to open the floor. Anybody would like to ask questions while we're also sort of monitoring the chat. So we'll open the floor at this point for any questions regarding the guidance, but also for the panelists. And then we'll sort of go to the Q&As and see, try to resolve the questions that have not been answered. So if you could raise your hand and ask any questions if you have for any of us.
Yeah, thanks, Santosh. So just to ask everyone to please raise your hands if you have any questions. But maybe we can also, while they're doing that, let's take some questions from the Q&A. I can see there are some comments on the Q&A. Santosh, do you want to take a lead on that?
Okay, I think most of the questions, a few of them have been answered. Thank you, panelists. I think there was a question from Sewang in terms of the country reaching an elimination status, having 97%, and what is the recommendation for campaigns and with age group, and Balcha has answered that. And I think it's WHO's statement around saying that if you have a coverage of more than 90 to 95% in 3 consecutive years, a campaign is really not recommended. But I think if you have a certain sort of immunity gaps that's documented in a certain group of people or certain birth cohorts, then this perfect strategy that we just discussed about targeted and selective strategies is very important. The next question is, I think I have colleagues from the questions for panelists for India and for Rwanda. Maybe I'd hand it to Dr. Ratnesh, and there is a question for you stating, how will you identify unvaccinated children over 5 years if the immunization card is often lost?
Yeah. Thanks, Dr. Santosh. That is a very interesting question. This previously, as I was mentioning, like if it is a non-selective campaign, this sort of issue is not there. We just vaccinate. But being a selective campaign, how to identify this 5 years, this is something which we have discussed over a length. Because it was a challenge previously, and what we have developed is a two-pronged approach, as I was mentioning, that less than 3 years, what is the approach, and 3 to 5 years, 3 to 10 years, the school-going approach. Majority of the children, if they are above 5 years, they will be in the school unless they are drop out from the school. That school dropout, I'll come out later. And if they are in the school, what approach we are following is we are entrusting the responsibility to the education sector itself, education department itself. And then the school principals will be trained, build the capacity. And from the education department, the teachers will be responsible for collecting the vaccination cards of each and every student which is there in that particular age group, in that particular school. And if the immunization card retention, the card subsequent question is also coming, the less than 2 years, the card retention is around 90% in country. And more, if we go above around more than 5 years, it will be less than 50%. Now, what is happening is the school will be first asking the parents to give the vaccination card. We are expecting around 50% will come out with some vaccination card or proof of vaccination. If the vaccination card is not there, we will be considering that child is unvaccinated, and then we will be going ahead with vaccinating that. So we at that point of time, we will not wait for to create a card. But once there is no evidence of card in more than 5 years, we will consider that child is unvaccinated, and then we will be taking them for vaccination. I hope that clarifies. This is the approach which we are going to follow in the country, India.
Yeah, go
Yeah,
on,
so
Oni.
thanks, Ratnesh. Yeah, thanks, Ratnesh. I think this is really key. We have two hands up. Maybe we'll just take that and then we can come back. Oluchi Basi, and then after that we have Christopher Waswa.
Good morning, good afternoon, colleagues, and many thanks to the entire team for this webinar, particularly to our panelists. I just wanted to ask our Indian colleague, it was really very insightful to hear you share excerpts of your experience in India. And it caught my attention when you mentioned children consistently being missed, even when they are being targeted. It's like you can't find the population that you want to vaccinate. And this is kind of like a very strong, sticky issue within the Big Catch-Up program, which is where I'm privileged to work in. And so I would just really like to hear a bit more from you. How did you pass that gap where you have this target population on paper, whether by whatever relevant documentation that you have, but you can seem to find them, and it might be because of displacement or whatever other concerns, and you keep going to the community and there is a chance you are vaccinating the same people. How do you go past that to be sure that your head counts, your vaccinations is still not the same people, but this missed children that you're really looking for? Thanks. Just stop there.
Thanks, Oluchi. Maybe we'll have Ratnesh. Do you want to come up and respond, and then we can move on to the next?
Yes. Thanks, Oluchi, for the very interesting. Yes, that is the main crux what you have mentioned right now. It's a very challenging one. It is not easy to conduct a headcount survey and enumerate as simply as enumerating all the unvaccinated, under-vaccinated, listing them and providing them vaccination. These are the children who are initially reluctant to get vaccinated. That is why they have dropped out many. And again, if you are going back to them, they will have some reasons. So these are some challenges. And one thing what we have been noticing here is it is not across the country the same phenomena. In some areas, it will be more of a vaccine hesitancy. Some areas where we call as fence sitters. Maybe the awareness gap is there. That is what our monitoring finding is also telling us. Still the awareness gap, because after the pentavalent third dose, which is at 3.5 months, there is a huge gap between 3.5 months to 9 months. That is the first dose of measles. The people tend to forget. The parents tend to forget of getting the measles vaccination. So the awareness has to be reinforced. and the parents has to be given the message. That is something. And coming on to the identification, it is not only identification, mobilization also. It is mobilization of beneficiaries to the session site. It is also a big challenge. These are something which it is still creating a bottleneck, but we are creating additional session sites wherever there are gaps are there. And if we have like for intensified mission in the Dhanush, what has to be done is we usually for routine medication we have weekly once. For maybe that one day is not sufficient for that parents because they are working and it is on the middle of the day. They cannot take leave to come for vaccination. For that, for catch-up campaign, we give the vaccination on all days of the week, all the days, and it so that even if they are missing, they can come back and they can take any point of time. It is more of a community demand, and they can take the vaccination. So these are something which we are taking it up, but still, I fully agree with Oluchi that there are some uh, issues how to do the head count survey. That is something. Thank you, Oluchi.
Thank you. Thank you so much, Ratnesh. Abdul Jamal, your hand was up, but it's down now. Do you want to take your comment? We can have you come up if you're open to taking it. Abdul Jamal? Okay, and maybe while you're deciding, we have a feedback from George Opoku. He says, I am of the view that a key ingredient for targeted vaccination is a very sensitive surveillance system that is able to detect index cases as early as practicable. The targeted campaign then helps to direct limited resources to address and prevent cases from spreading to other geographicals. And I think that, Ratnesh, you actually made this point when you were talking about cost efficiency. Hassan too talked about this when we asked him about the cost efficiency of effectiveness for targeted campaigns. So George, thank you. And just to encourage everyone, please, we would like to hear from you. Share your comments or your thoughts on the Q&A or on the comment section, and we will take them here. Abdul Jamal, you have the floor.
Yeah, thank you. Thank you so much, colleagues. And this was a very good discussion, and thank you for the panelists. I think most of the question I was having already been answered. But again, I just wanted to go back to what Murugan was talking about the issue of confirming if a child has already gotten the vaccine or maybe using the vaccination cards. Do we have opportunities where if a mother has lost her card and we can recall, maybe from the recall from the mother is actually positive and confident about a child being vaccinated, can we be able to actually accommodate that to our vaccination, just to actually put the aspect of immunization that has already been happened or that has already happened, or maybe we need also to vaccinate again? That is one. Thank you, Dr. The last panelist talked about equity. Very interesting, because we really have a lot of challenges, and I'm happy for him pointing out the aspect of multiple actors in implementation.
I think Onu is lost again, right? So maybe, yeah, no, thanks a lot, Abji, for this question. And I think to your point around not having the vaccination card, right? Like, and as I alluded in my presentation, right, the selective strategies, at least where we are making a very high cutoff, 90%, which is not really clearly based on evidence at this point, but that's why we're calling this guidance an interim guidance, as we are working with across partnership at a global level to sort of create more evidence around these strategies. But the selective strategies of the 90% cutoff, it really says documentation, right, of home-based records, electronic-based registers, or even manual registers, or immunization registers. It really talks about having the documentation in order to make that cutoff of 90%. So this is what the guidance mentions, but again, at the country level and in a setting, right? Like, I think it's a little different, and even the oral opinion of being vaccinated is sometimes taken into consideration. Yeah. Let's take a few more. Do we have any hands? Oni, are you back?
Yes, we have a comment from Sylvester here. He says one advantage of maybe Sylvester, do you want to come up and just talk about this? Because I think it's really very important. And then we can have Dr. Hassan really speak to this, because I think Rwanda has an excellent example of targeted strategies. Bacho's hand is up, but Dr. Bacho, do you want to come up first? Maybe, yeah.
Yeah, thanks so much. Just to put into context, I think, as I mentioned, this discussion about targeted selective campaigns has been going on for some years, at least for about 7 to 8 years. And attempts were made in order to identify eligible countries that would probably try out this. And we have had a number of attempts, but based on the reasons that I mentioned earlier, the quality of the data, the ability and confidence to triangulate using the data that is available to us, particularly as you disaggregate towards the first subnational level and the second subnational level. Unfortunately, we only have administrative coverage, for instance. You may rely on coverage survey, but coverage survey is often done to give you a national level estimate, or at best, a first subnational level, provincial level estimate. If you want to disaggregate and make a decision for selective or targeted vaccination for the district level, usually coverage survey results are not available at that level. So you'll be obliged to go with very imperfect district administrative data. So out of the 7 or 8 countries that we have tried to engage with since 2018, 4 countries have basically said, no, our data is not of good quality enough, and we do not want to go down that road. So they have reverted back to nationwide vaccination for very good reason after looking at their data. So the few examples that we have, Rwanda is one, which is excellent because the country has enjoyed actually very high routine coverage and fairly low incidence level of measles for many years. And the level of data that they have has allowed them to drill down and look at where exactly they should target. So they made that calculation based on a selective approach, and also extending the age target up to 6 years of age, as opposed to the usual 9 months to 5 years bracket that we usually take as a standard. But because their campaign was at least 5 years, 6 years inter-campaign interval, they went up to 6 years of age because their immunity profile showed exactly that. Senegal was another country where a very highly selective approach was used. The country opted to do a head count of all under 5 kids, register unvaccinated children using community health workers. So people who went through the villages to register and record all unvaccinated children came up with a list, and then the vaccination effort was supposed to target those same children. Now, we feel hindsight is always 2020. We now feel that there was a challenge with regards to the initial identification of unvaccinated, because there was a huge underestimation of the level of unvaccinated children in the community. So the initial list that they brought, the 200,000 children list, was far too small compared to the number of unvaccinated children expected to be out in the community, based on crude calculation. And then secondly, when the vaccination exercise was done, very highly selective vaccination, finding 200,000 children across the territory of Senegal, eventually the coverage figure we had definitely was not satisfactory enough. But surveillance also showed us that immediately after the campaign, the country started experiencing outbreaks across the country and across bigger age groups, even going all the way to school age group and beyond. So to a certain extent, that exercise was a failure because the right strategy was not used, and the selective approach may not have given us the result we need. Was it cost effective? I think Santosh has mentioned it earlier very well. a selective strategy that goes twice to the household. First, to identify unvaccinated children. Second, to go and find and vaccinate the children. That was not a very good use of resources, particularly when you look at the immunity profile right after the campaign and the outbreaks. Definitely, it was a waste of resources. So I think we need to balance it out very well. Another country that did that similar approach was Eritrea, highly selective approach, but they have the manpower, they have sustained high-level coverage for many years. And even though we do not have a post-campaign coverage survey after the campaign, 1 year later or 1 year and some months later, I can tell you that they still do not have any sizable number of measles cases, which attests to the fact that they have managed to reach unvaccinated children during that exercise. So the whole point of a campaign, be it targeted or selective or non-selective, is to reach those children who are not reached before. I think we should not forget this key takeaway. The whole reason why we do a campaign is not to vaccinate the same kids, is to identify and vaccinate previously unreached children. Thank you.
Yeah, thanks, Boucher. I think these are really very, very important points. And I just want to highlight something that has been said here by Boucher, which looks at the importance of data quality. You can see the slide that Santosh talked about on your screen. And one of the things it says here is the decision to use a targeted strategy should be guided by an assessment of the availability and quality of data. And that's really key. So we're going to share this presentation with you. We want to encourage you that you go through it. There's an algorithm there that would help you to decide what path you should actually take. And just like Boucher said, a one-cap-fits-all approach, it's not the case here. It's important that countries go through that rigorous process of decision-making, evaluating the quality of their data, the confidence in the data, and the decision-making processes that we have outlined in this presentation here. So thank you, Boucher. I think these are really very helpful comments. Again, just to add that different countries are at different maturity levels. So for example, you had the discussions from India, and of course you had Rwanda, but you also are hearing now a very balanced view from countries like Senegal, where there were challenges with the data that ended up affecting their selective approach. I want to take, maybe Santosh, your hand is up, and then back to Sylvester again as we wrap up.
Yeah, thanks, Oni. I mean, did we want to invite Rwanda to sort of intervene at this point? That's one. And there's just one unanswered question in the Q&A in terms of step 2 and step 3, the sequence. It really depends on the country, right? I presented the step 2, which is more around targeted age ranges, right? Because when a country plans a campaign, it's by default they go for what age do they want to target first, right? So that's why that comes in step 2. But countries could either determine certain groups of people or geography, whether it's subnational or nationwide. It really depends on the situation of the country. It's not hard and fast that you have to follow this step 2 and step 3 in a sequential manner, but it's just in terms of the situation that I presented in. So over to you.
Yeah, thanks, Santosh. And it's good you brought up Rwanda again. Maybe we'll ask Sylvester, sorry, just a minute. Dr. Hassan, are you there? Could you want to comment a bit on your country?
Yeah, thank you, Santosh. Thank you, Dr. Oni. So it's very important, actually, what has been discussed here about having actually records. So for us, actually, we are very happy that actually today we are fully digitalized today. So we are no longer actually providing vaccination card to caregivers and parents. So what we are doing today, actually, once the child is vaccinated, we just send, the system itself actually sent SMS to parent or caregivers, and with that message, actually, there is a link where actually parents can download vaccination card. So, and then on our side from our office, we can easily have the list of children who have not been vaccinated. So it's very important because today now vaccination program is somehow linked with the birth registration. So we can easily collect individual data. So meaning that actually in near future, So we think that actually we are no longer going to have even immunization coverage survey, because definitely we have lists of all children born and vaccinated. So it means that actually once we plan for another immunization coverage survey, so in that case actually we go through database actually and analyze data instead of wasting again resources and they go to the field and collecting data. So it means that actually for us it's very easy. If the child miss actually vaccination appointment, it's very easy actually to go through and they have the list. And again, because we have even their phone numbers, so we can call parents for bringing the children actually for vaccination for the nearest actually health facility. Yeah, thank you.
Thank you, Hassan. Thank you so much. Really, really spot on. And again, you provide credence to the high quality data in Rwanda that made your program a success. Maybe Sylvester, sorry, we've put you on standby for quite a while. Maybe just 2 minutes to share your thoughts, and then we'll take final comments from our presenters as we move on.
Well, thank you very much, Oni. Thank you for the interesting conversation. I just want to re-echo just two things quickly. You know, when we talk targeted and integrated campaigns, I think one thing comes to my mind, coming from a coverage and equity lens, is that this actually aligns with our equity and impact goals. It's very important, especially in setting where campaigns remains the most reliable health delivery vehicle. I think it's clear. And I agree very much with all what Dr. Bacha said in terms of, you know, why we keep on echoing the fact that it saves resources. We've had situations whereby targeted selective campaigns that are integrated might not be the best cost-saving mechanism. But for us, at least, we're sure that equity and people that need this gets it the most. I think that's at least with the cap I set up. And again, looking at the donor landscape right now, you know, donors want to see results. And that's why I chipped in that message. You know, when you do a targeted and selective campaign, for example, where you're having outbreaks, et cetera, and it's able to, you know, stem that outbreak, the donors see the result. There is trust, not only from the donor part, but also even from the community part of view. You know, so it helps generate much more interest in our program, as the case may be. So those are just some of the things I wanted to chip in as we keep on having these discussions. Thank you very much, Wani.
Thank you, Sylvester. Again, really very, very insightful comments, and thanks a lot for the emphasis there. We will have one last comment from India, Dr. Ratnesh. Just 1 minute to give your closing remarks, and then we will come back to Dr. Boucher and Santosh.
Okay, thank you so much, Dr. Onyewu, and then this entire seminar was very good, very helpful. And then I lots of my colleagues are there from India who are also listening to this interim guidance. It is very helpful to all of them. And all these guidelines, we will be sharing it across to them, this presentation, and very, very thankful to all the support. And I'm sure there's no other Q&A pending from my side. Dr. Onyewu, it's fine, no? Done, no? All the questions?
Thank you. And thanks, everyone. So we've shared again the link for the interim guidance. It's on the chat box. Please feel free to download it. And we're hopeful that it will guide your decision making and steps towards having quality campaigns. Dr. Boucher, maybe last comment from you, 1 minute, and then we'll move to Santosh.
Yeah, thank you so much, Oni, and thanks, colleagues, for the questions that you raised, for the comments. I think these were really, really good. It shows the level of interest. It shows the level of engagement of the participants. We're really honored. With regards to what was discussed, I think please go through the document, go through the interim guidance at your leisure. If you have any questions, we remain available to answer at any point. And as I said, the whole point of campaigns is to reach unreached children. Not every country may have the confidence to jump into targeted or selective vaccinations, but tailored approaches are for everybody. And I would like to strongly emphasize on that and invite you to look into how best we can reorganize our approaches, our messaging, our logistics, our HR in such a way that we can address the realities on the ground and reach unreached children. So for every country, there is room, multiple rooms for tailoring your approach whenever you are going to be doing campaigns. And of course, the basis for VPD control remains routine immunization. So we focused our discussion today on campaigns, but that doesn't in any way take away the importance of routine immunization. And as much as possible, the most sustainable way of maintaining high population immunity remains attaining high coverage through both doses for measles and measles-containing vaccines in particular. Thank you so much, and back to you, Oni. Thank you.
Thank you, Bacha, and I really want to thank my esteemed panelists. Thank you for the excellent feedback, and thank you for all of the ideas and thoughts you've shared with everyone within this community. I'm sure that you all found it very helpful, and we're hopeful to that you would continue to look at the guidance and reach out for support should you need them at the various levels that you are in. So I want to really thank you very much. And at this point, I think I would like to invite Santosh for the closing comments and just to say thank you from my end. Santosh.
Thanks, Oni, and really thanks for all the excellent panelists, but also a very engaging audience, right? I think it was very, very well received from our end. And I said, like, during the framing of this guidance, we really wanted a country-centered approach, and we approached countries in drafting this guidance, but happy to sort of work with countries if this needs to be more tailored to a country context, working with the regions, with the regional colleagues. So please reach out, and thank you once again, and have a good rest of the day. Bye-bye.
Bye now. Thank you.
Thank you.
Thank you. Bye.
Thank you, everyone, and goodbye.
Thank you.